So now I invite all of the presenters to turn from this afternoon to turn your cameras on. We'll have our panel discussion now. And if people have questions, feel free to put them in the chat or to turn your camera on, raise your hand, take yourself off mute if you'd like to ask a question yourself. But I can get us started with a question for Davina and Mark. So how is a patient-oriented approach to knowledge mobilization different from those usually adopted?
Thanks, and apologies, Mark was unable to stay for this piece. And I think more and more the notion of really being intentional about that partnership with patients is what makes it different. And that's why I tend to use patient-oriented approaches, because it just puts upfront that is the intention. I think over time we've seen this change, and so in Kristi did such a good job of speaking to the diverse ways that we communicate with different audiences, and I can't wait to learn more about that project too. And we know that traditionally a lot of researchers were very much only concerned with kind of sharing their findings with academic audiences or a limited range of stakeholders. And I think being upfront and intentional around, sharing that knowledge with people with lived experiences as well as diverse audiences is important. So I think it's what makes it different is, one, the intention, but also adopting methods that are inclusive and things like plain language, making resources really tailored and targeted, and really thinking about, what you want to say and how you want to say it. And I think, as the other presenters today also demonstrated, is to do that we do need people with lived experience to be centrally involved and centrally engaged in directing that process.
Thank you, Davina. Sandra, I see you have your hand up.
Yeah, thanks, Sarah. So shout out to Can-SOLVE, because I think your group is leading the way when it comes to patient partnership and the work that you're doing. Second presentation was amazing, but I'm biased. It was great. Thank you. Great work, something that's been needed for a while. Davina, I love everything that you're saying about the knowledge translation. I really think it needs to. I did see and exactly what you just said. As a patient partner, it seems like, you do all the work. And even if a project takes time, it's also the knowledge translation, like those little death valleys that you talked about. But there's also death valleys for a patient partner where the work is continuing, but we're not hearing anything back. So it's regular updates as well, which I consider part of the knowledge translation. But it's almost like the project's done, it gets published, and then it's like, ta-da. But for the patients, it's like, no, like we need to get it in clinic and we need to get it out there. So first of all, I definitely think it should be written right into the project and committed to. And that's why it's the importance of having patient partners right at the beginning. My question to you is, what do you think are the best ways to get the information translated to patient partners and the general public?
So really great points. I think in terms of translating evidence and knowledge to patients and the public, I think ideally, you want to be knowing the needs of your community. And so I really believe that engagement, when we ask, we get the answers we need, and I think it's being prepared to follow. And I always say for researchers, we have to leave the ego at the door. We have to leave those old rules behind and be prepared to follow the lead. And I think, and you mentioned about that early engagement. And so, I think when we start with that patient experience, we start with the patient voice and we build from there. It also comes down to kind of a similar process. We have to be willing and ready to follow the direction and follow the recommendations. And I really believe strongly in that. And I think we have some barriers. We know our funding, the ways of funding are not great. We have these long periods, you're right, where perhaps, you've put all this work in a grant and you don't hear for a long time. And, communication is key, but I think we all have a role in continuing to engage people right up front and right to the very end. And I think just keep pushing and keep advocating for the importance of that. And but yeah, I think we still have a lot to learn too.
The other thing I wanted to pull emphasis on too is that the first valley, this is what concerns me, and this is where I think patient partners have helped, is even when the question is being determined, right? So CTRP, when we met in 2015 with a bunch of people that would be interested in being patient partners, we prioritized a list of what was important to patient partners. And I constantly go back to that and see if we're covering it. But I think researchers would be better served, they would probably get more funding if they asked first before they even proceeded, is this something that the patients want? Is this something that will benefit patients? And then that way, then the questions start, the engagement starts, and then the application process gets done. And I think you would have a better chance of getting more funding.
Yeah, I've definitely been working that way myself. That's fundamentally, I think, for me, where I'm at. But I'm curious for the other groups here too, because we know, like, and I know CDTRP well, I know Can-SOLVE well, such a great load of work. I'm curious for the networks, you know, those that have been engaged too, like how they see that process of getting that voice right up front, because you guys have been really innovative and instrumental in that.
I see Mary has her hand up. I don't know if you want to weigh in on this.
Sure. I just wanted to ask Alicia and Linnea, I know you're not involved in the day-to-day aspects of the projects that are part of Can-SOLVE, but can you recall any time that patient involvement really changed the direction of a project?
Well, I know for sure with Kidney Check, because I've heard the story from Kathy, blanked on her name, Kathy Woods. So Kidney Check is one of the projects in which they do point of care testing. They go into Indigenous communities and do point of care testing, testing a few things just by a blood prick and a urine sample and blood pressure to determine risk of kidney disease. So low, medium, or high. If you're high, then you get a referral. If it's medium, you get some some education from a nurse about ways to help to reduce your risk, and also what to look out for when you should see a doctor. And I know that Kathy Woods, who is one of our patient partners in Winnipeg, she was part of this, and they were originally going to do a traditional double-blind placebo-controlled trial, which some communities would get this point of care testing and education, and some wouldn't. And Kathy was very adamant and vocal about the fact that that is not how we do things in the Indigenous, I should say, sorry, that Kathy is an Indigenous woman. This is not how we do it within the Indigenous communities. We do not have you have some and withdraw from the others. And so they did. They changed it completely. They go into these communities, but it is everybody gets the same thing. So it changed the type of research is done. It's not going to change the outcome because they're still going to see, because we're not in every community, obviously, but that is, the big one that we hear about a lot of how patients can change. And that is because there were patient partners while they were writing the initial draft. So that's, and we did that in Can-SOLVE when we were getting ready for phase 2. We had people come in right then. You need to get them. Don't come up with a question and then approach them saying, hey, we're going to answer this question. Do you want to be a patient partner? Have the forums, have these work groups, do the priority setting saying, hey, what do you want to know and need to know to make your care better? And then build it around that.
Mm-hmm. And I think one of the key things about Can-SOLVE was that there was a lot of priority setting at the beginning of phase 1 and even before we entered phase 2 as well. There was a lot of work done before even getting to before they started writing the grant application. So and the other thing to add about that story about Kathy was that she was really adamant on switching it from like a disease or deficit sort of based questioning or research question to a health-based question, and really turning it more into a positive. So I think there was a lot more buy-in as well. And things like that really help build relationships, especially with Indigenous communities. 3 of the 18 projects that we have at Can-SOLVE are Indigenous focused. So it was really important to build those relationships and take the time. Like I say, 75% of the works a lot of time is building the relationships and 25% is actually doing the project. But thank you.
Thank you, Mary. Great question. Marie Chantal, I see you have your hand up.
Thank you very much for all your outstanding and very informative presentation. My question is for Alicia and Linnea for the Can-SOLVE. So you've done great job. You've developed tools. I think you have been very successful at integrating the patient partner in your network. For the next 5 years, what are the challenges? What are your objectives? Where do you want to go with patient engagement? What is the future of patient engagement within the CKD? So I think it will be very informative for the CDTRP, but yeah, except if you tell us that you have a copyright.
No, thanks for the question. Alicia, I can start us off and then feel free to jump in. But yeah, so I think what we described in our presentation was very much about phase 1 of our network with our 18 projects and really bringing those to completion. So I think looking ahead, we're really focused on knowledge translation and mobilization. So that's kind of where we're at, and we're really trying to work with our existing partnerships and the relationships that we've built over the many years we've been an organization, and leverage some of those connections as we move into phase 2 and start to really mobilize the knowledge that we've created and generated in partnership with our patients. So in phase 1, we actually did have a knowledge translation community of practice where our research team members would kind of come together and learn about these best practices, how to involve their patients in this knowledge translation process. So I think that's something that we're definitely going to carry forward. And we are currently rolling out a series of workshops for our network members, 2 of which focus on knowledge mobilization. So we're just kind of scratching the surface of what this all means and what this can look like going forward. But I think step 1 for us is really to understand, what mobilizing knowledge looks like and means for us. And we'll be rolling that out over the next several years. Alicia, anything else?
Yeah, I just want to add that, one of the challenges we have had, and I see this too through my lens as someone within the CNTN, is that we are a very, vast country. There's a lot of people in the Vancouvers, the Winnipegs, the Toronto, Ottawas, but there are millions of people living in the in-betweens, and it is always a struggle to try to reach those people who don't necessarily always hear about it that aren't always coming to the big conferences and coming and seeing or aren't in large hospitals that have our flyers and things like that. So I think that's always a struggle to try to reach people that are in the rural, remote areas. And obviously a part of that in the more remote areas is that a lot of what we do is on Zoom to try to reach people, and some people don't always have access to suitable internet to do all these things. So trying to find innovative ways to connect with people. I mean, maybe that is just emails and saying, getting feedback or having phone calls with them to make them feel more involved and like their voice is being heard, and it's not just always the same people along the 49th parallel who have the say in what's going on in research in the country. So I don't have an answer for that, but I'm just saying that that's one of the struggles that I'm sure most of us who do nationwide research have. So
thank you. I see Patricia put a question in the chat. How are these innovative approaches to patient engagement being received by grant reviewers? Are they being welcomed and celebrated? I don't know if anybody in particular wants to answer that. Davina or Kristi, I see you took yourself
Kristi
off
first.
mute.
Go ahead, Kristi.
So I would just answer this maybe from two different sort of perspectives. So as a patient partner who's been involved as a reviewer in grant reviews, I would say that it has been a process, that there's a lot of education that is needed to really help ensure that the more scientific reviewers understand what our role is, what our contribution is. And as they also witness what feedback and insight we're able to give and add to the process, they are very welcoming to it. They start to learn more around what engagement entails, and also how the reviews really, or how our feedback as part of reviews can add additional insight that they, as scientific reviewers, may not have considered related to the projects. And then as a funder, so I'm going to put that hat back on as my role at TRF. I would say that it has also been something that's been quite an evolution and a process. When we first started doing that as our own organization, I would say that there was a little bit of pushback. They didn't understand. There was confusion. They didn't understand what we were going to be looking at, how we were going to be considering more the engagement component. They were worried that we didn't have the scientific training. But upon, again, further education, they came to appreciate, understand that that's not what we were there for. We were really there to look at these applications and projects and research from that persons with lived experience lens. And I can say that after, a couple of years of this and becoming more familiar with it on their end, that the feedback was really encouraging and supportive, and that they actually said that the patient family partner reviewers were bringing forward concerns and questions that they would never have thought about. And it was really enriching the overall peer review experience. So Davina, your thoughts?
Yeah, I love that you raised some really great points there. I've sat on quite a few different review committees, and I think funders now increasingly expect to see people with lived experience engaged. But when I think there's an increased expectation, there's always an increased risk of tokenism. And as a reviewer, I can usually sniff it out. And some good telltale signs are, there's not a clear leadership role. There's no real sense of expectations around, how someone would be involved. And also a key thing for me as a reviewer, I always look for is, if there's sufficient compensation and it's appropriate, and there's actual plans to really value that lived experience. So I think funders are excited. Funders know the landscape is changing. They're supporting it. But again, I think the concern often is that it just opens the door, more and more I see people, almost every application I can read will say that they've engaged someone with lived experience, but when you look at it, you cannot see it. Or again, those things like compensation or clear roles or a real plan for how, even saying how people with lived experience have inform that project. So to me, those are the bits as a reviewer that I sniff out, and I'm like, yeah, this does not sound legit to me. But and I love to give feedback on that, because, when engagement is done badly, it can be harmful to people. People give their time, they can be disappointed, they can feel that they come away, sometimes harmed through the traumas of their own, they've been put in positions that aren't safe. And so I think funders have an instrumental role in supporting engagement of people, but we also have to, I think, as people that review for funders, be really quite hard on making sure that it's done in the right way. And I also think as well, funders are super excited to support, but some of the other barriers are even at the institutional level, like universities that typically hold the funds. Our policies are outdated. It makes it really hard to compensate people with lived experience that have contributed actively in a timely way. And that's another bugbear of mine, and something I constantly raise, that we have to do a better job of one, how we recognize, how we engage, and also, how we recognize. And again, that compensation piece is really important. It may not just be money, it could be training. It's about providing that remuneration and that recognition in a way that's meaningful for people with lived experience and is helpful and reduces barriers. And so I think funders have a lot to do, but I think it has to come through our whole systems.
Thanks, Davina, and everyone who weighed in on that. And just there was a question related to guidelines on peer review processes. So tomorrow there'll actually be a session on grant review. So we might just table that for that discussion tomorrow. And I think Kristi, you're involved in that session, correct? Yeah, perfect. So I might just pivot a little bit and ask a question maybe to Carrie, because we haven't heard from you yet. So why do you think it's important to have patient engagement and patient-driven projects such as the My Transplant Experience project?
Sorry, I was on mute there. I think everybody's really touched on that already, but it's an integral part of safe and people-centered healthcare. And it helps ensure that the services and the resources that are offered to patients are responsive to the people that they're meant to serve. And importantly, of course, engaged patients do tend to be better informed and better able to advocate for themselves and their families.
Great, thanks. And Kristi, do you want to add anything to that?
I think just a little point about, I mean, and it's been really highlighted, I think, throughout the various discussions today, but that why it is also so important is really because what patients and caregivers, or again, persons with those lived experiences of the topic in question, what they may identify as mattering to them and being in need is likely to be a little bit different or even a lot different than what researchers and other healthcare professionals may identify. And again, it's about bridging those two worlds to really ensure that we're hitting kind of the nail on the head a little bit more.
Thanks, Kristi. Related to that, and I mean, anyone can weigh in, how can we encourage more patients to take part in sharing their lived experience to influence policy change and quality improvement in health? And how can we make that easier?